Good afternoon, guys. Today we have lecture Acute Ileus. Intestinal obstruction is a pathologic state which results in the disorders of peristaltic activity. As a rule, this condition is accompanied by pain in the abdomen, nausea, vomiting, retention of stool and gas. According to the date of the institute named after Sklifosovsky, acute ileus is predominantly the disease of adults. People at the age of 20 and elder make up 86.5%. Children at the age up to 15 fall in 10-11%, and teenagers and years 15-90 years in 3.54% of cases. Classification: according to origin, into congenital and acquired. According to mechanism of initiation, into mechanical and dynamic. Dynamic form is subdivided into paralytic and spastic one. According to the presence or absence of embarrassment of the mesentery vessels, which deliver the bowel into strangulated with vascular embarrassment of the mesentery. Obstructive without embarrassment and combined or mixed, in which obstruction and strangulation are well made simultaneously, as it happens in invagination. According to clinical course, into acute, chronic, complete and partial. According to location, into upper intestinal ileus and ileus in the lower intestine. Mechanical ileus. On this picture you can see reasons of mechanical ileus. May be obstruction, constriction, compression, or angulation. On this picture you can see strangulation, inversion, torsion, knot formation, adjacent process. Etiology. Causes of intestinal obstruction are diverse. The development of strangulated intestinal obstruction is associated with congenital or acquired organic changes in the abdomen. The following congenital abnormalities may result in acute intestinal obstruction: dorsal common mesentery of the ileum and cecum, mobile cecum, excessive length of sigmoid column, mesentery and megasigmoid, Meckel's diverticulum, Spigelian line and diaphragm defects. Acquired changes occur due to abdominal injuries, surgical intervention, and abdominal inflammatory process. Anatomical changes: excessive mobility of one or another portion of the intestine. The presence of strangulated gates create the necessary prerequisite for origination of strangulated forms of mechanical ileus, valvulus, formation of knots, strangulation, and invagination. Obstructive ileus may result from certain physical phenomena, which cause alteration in the intestinal lumen. At first, the blood flow doesn't suffer. Such phenomena may include the large intestine obstruction with malignant growth, obstruction with impacted faces or gallstones, with foreign body, with ascarid bowel, sometimes with scary constriction, with twist or constriction of the bowel with commissure, which doesn't compress the mesentery. Obstructive ileus. With obstructive intestinal obstruction, the blood circulation at the level of microcirculation is broken for the second time due to its excessive stretching of the intestinal contents. Therefore, during obstruction, necrosis or perforation of the intestine may develop within a few days. The causes of spastic ileus may be the disease of the nervous system, hysteria, spasmophilia, dyskinesia, helminthic invasion, colonic polyps, and narcolepsy. The other causes: it is possible to refer any inflammatory process in the abdominal its phlegmons or hematomes of the retroperitoneal space, post-laparotomy state, reflex influence of extraperitoneal pathologic conditions, pneumonia, pleurisy, myocardial infarction, mesenteric vessel thrombosis, infectious disease, toxic paresis. Pathogenesis. Humoral disorders associated with the loss of large amounts of water and electrolytes and proteins. Hypovolemia and dehydration increase the production of antidiuretic hormone and aldosterone. As a result is a decrease in the amount of urine excreted by the reabsorption of sodium and significant excretion of potassium. Potassium is excreted in the urine and is lost with vomit mass. A low level of potassium in the blood is fraught with a decrease in muscle tone by a decrease in myocardial contractility and inhibition of intestinal peristaltic activity. Endotoxicosis appear to be an important link in pathophysiological process in intestinal obstruction. The fluid in the afferent loop consists of digestive juices of the food heme and transudate. It contains plasma protein, electrolytes, and blood cells, which enter the intestinal lumen due to increasing permeability of the vascular wall and condition of impaired intestinal passage, the decrease in the activity of cavity and parietal digestion, and activation of microbial enzymatic cleavage. All quickly decomposes and rot. This is facilitated by the reproduction of microflora in stagnant intestinal contents. With the acquisition of the dominant role of symbiotic digestion in the intestinal heme, the number of products of incomplete hydrolysis of proteins, various polypeptides being representatives of a group of toxic molecules of average size increase. In normal conditions, these and similar compounds are not absorbed through the intestinal wall. In conditions of circulatory hypoxia, it loses the function of the biological barrier, and significant portion of toxic products enters the general bloodstream, which contributes to an increase in intoxication. Impaired motor and secretory resorptive function of the intestine. In the early stage of abstraction, peristalsis increases. At this stage, the peristaltic movements in the afferent loop are shortened in length, but become more frequent. Stimulation of the parasympathetic nervous system while maintaining an obstruction may lead to the occurrence of antiperistalsis. Further, as a result of hypertonic sympathetic nervous system, a phase of significant inhibition of motor function develops. Peristaltic waves become more rare and weak, and in the later stage of obstruction, full intestinal paralysis develops. This is based on the increasing circulatory hypoxia of the intestinal wall, as a result of which the possibility of impulse transmission through the intramural apparatus is gradually lost. Then the muscle cells themselves are unable to perceive the impulse to reduce as a result of deep metabolic disorders and intracellular electrolyte disturbance. Metabolism disorders of intestinal cells is aggravated by increasing endogenous intoxication, which in turn increases tissue hypoxia. Clinical picture: it's pain, abdominal distension, vomiting, stool and gas retention. Pain. Pain usually occurs suddenly, regardless of food intake at any time of the day, without any precursors. With obstructive abstraction outside the cramping attack, they usually completely disappear. Strangulation obstruction is characterized by constant sharp pains periodically increasing. Paralytic intestinal obstruction proceeds with constant dull arching abdominal pains. Vomiting. Vomiting is the first reflex in nature. With continued obstruction, vomit is represented by stagnant gastric contents. In the late period, it becomes indomitable. Vomit acquires a facial appearance and smell due to the repeat reproduction of Escherichia coli in the upper digestive tract. The higher the level of obstruction, the more pronounced vomiting. In the intervals between vomiting, the patient is nauseous, worried about belching and hiccups. With low localization of the obstruction in the intestine, vomiting occurs later and proceeds at long intervals. Stool and gas retention, pathognomic sign of intestinal obstruction. This is an early symptom of low obstruction. With its high character at the beginning of the disease, especially under the influence of remedial measure, there may be a stool, sometimes multiple, due to the emptying of the intestinal section of the low obstruction. Clinical picture and diagnosis of strangulation intestinal obstruction. In most cases, the disease occurs suddenly. There is severe cramping pain in the abdomen in 100% cases. Recurrent vomiting 60%, which becomes facial by the end of the second or third day. In very severe cases, vomiting doesn't run to the limit of uncontrollable, and patient die early. Absence of stool is noted in 80% of cases. Abdominal distension in 75%. The urine is excreted in small amount, but frequently complete anorexia takes place. The severity of state depends on the stage of the disease, initial stage, stage of intoxication, or a terminal stage, the type of obstruction and general somatic state of the patient. Uneasy behavior of the patient, searching for position of the body to relieve the pain takes place. The skin integuments are pale and covered with cold perspiration. The eyeballs become sunken and voice soundless. Consciousness is clear. Delirium and convulsion are rare. Temperature is normal or subfebrile. The tongue is dry. Bad breath take place. Tachycardia and lowering of arterial pressure occur. At the onset of the disease, the abdomen is slightly distended. Then bloating increases. Asymmetry of the abdomen appears, especially in case of ileus in the lower intestine. In thin patients, asymmetry of the abdomen may associate with visible peristalsis of the afferent intestinal loop, false symptom. Tenderness over the whole abdomen, which may be sometimes more pronounced at the site of barrier is noted on palpation. At early stages of the disease, the abdomen is soft and rebound tenderness symptom is negative. Splashing sound, its scleral symptoms, is determining in the intestine, and in case of colonic obstruction, meteorism in the right ileocecal angle and Schütz symptom is noted. In cases of visible intestinal loop, its percussion causes increased peristalsis, Schlange symptom. Over the distended loops, there is a high tympanitis. Later, in the presence of exudation, dullness of percussion sound in flat portion of the abdomen is determined. Auscultation helps to determine intestinal murmurs, which increase with onset of attack of pain, sometimes at distance, and later at the terminal stage, falling drop sound and daily silence symptom. On rectal examination, a balloon-like distension of ample of the rectum and incompletely closed anus, Hochenick symptom, is revealed. In case of valvulus of sigmoid colon, it is possible to inject by means of enema not more than 0.5 liter of fluid. Strangulation intestinal obstruction develops very rapidly. In severe cases, when a large site of the bowel is impaired by strangulation, it may result in fatal outcome in 12-14 hours. Symptoms and course of the disease in obstructive ileus differ. They depend on gradual or sudden intestinal obstruction. Congestion of intestinal contents in the afferent loop leads to increased peristalsis. Subjectively, it is accompanied by attacks of pain in the abdomen, which tend to recur and locate at the same place. At the onset of the disease, especially in case of slow development of narrowing, there may not be any dilatation. It develops and becomes persistent only at the stage when compensatory hypertrophy of the bowel musculature becomes insufficient. Then constant abdominal distension develops, which lead to paralysis of intestine. Gradual overfilling of the afferent loop causes paralysis of the pylorus and peristalsis cases. Note the vomiting, eructation, and then abundant vomiting with fluid vomit mass, which has overfilled the intestine and the stomach upper. Pains pass when peristalsis cases. Acute obstructive ileus is developing during few hours, and its clinical manifestations coincide in many respects with acute strangulation intestinal obstruction. Additional methods of investigation, laboratory methods, and blood investigation in particular reveal leukocytosis, deviation of the stabbed neutrophil count to the left, hypokalemia, hyponatremia, hypochloremia, hypoproteinemia, and dysproteinemia. X-ray examination. Plain radiography reveals Kloiber's cups. On contrast, enterography, Schwarz test or probe enterography, retention of contrast substance at the area of abstraction takes place. Ultrasonic investigation reveals bowel distension with horizontal level of fluid. Endoscopy. By means of rectomanoscopy and colonoscopy, it is possible to reveal certain causes of colonic obstruction: tumor, coprostasis, ring bodies. Recanalization of a bowel area blocked with tumor, polyp, and foreign body excision are possible. Laparoscopy reveals intestine status, presence of exudation, and peritonitis. It is possible to transect adhesions under visual control. On this rentgenogram, you can see Kloiber's cup symptom. It's same. On this picture, you can see irrigoscopy with block on the level of transverse colon due to tumor. On this picture, you can see invagination and tumor of sigmoid colon. Sonography, ultrasound examination, we can see dilatate of lumen of intestine and thickness of wall of intestine. It's signs of intestinal obstruction. CT scan, we can see a dilated of lumen of intestine, thickness of wall intestine, and tumor like reasons of intestinal obstruction. Treatment. The scheme given below determine the main tasks of treatment in acute ileus. First, restoration and maintenance of the body internal environment. 1. Accurate compensation of fluid by means of estimation of its loss with vomiting, transudate in the abdomen and in the intestinal lumen, with urine and other losses under control of diuresis. 2. Compensation of electrolytes deficit and potassium, sodium, and chlorine first of all. 3. Administration of mineral corticoids. 4. Compensation of extracellular protein losses by means of albumin, plasma, blood, and other transfusion fluids. 5. Compensation of erythrocyte loss in strangulation intestinal obstruction. 6. Elimination of acid-base imbalance, more frequently metabolic acidosis. Second, improvement of internal function. 1. Heart. Administration of cardiac preparations. Glucose restoration of blood circulation volume. Elimination if microcirculatory disturbance. 2. Nervous system. Oxygen therapy. Prevention of brain edema. Pain relief. 3. Liver. Administration of glucose in combination with insulin, vitamins B1 and C, glutamic acid, and proteins. 4. Kidneys. Control of diuresis, adjustment of normal amount of fluid, recovery of oncotic pressure by transfusion of albumin or polyglucin, improvement of renal blood supply by means of paranephric block. 5. Adrenal glands. Administration of vitamin C and glucocortisone. Thought. Control of pain shock. Appliance of narcotics and analgesics. Paranephric blocks. Intraoperative novocaine injection to the root of mesentery. General anesthesia during operation. 4th. Fight against intoxication. intravenous and intraperitoneal introduction of broad-spectrum antibiotics, administration of glucocorticoids, thorough elimination of transudate from the abdominal cavity, sanitation of the abdominal cavity with great amount of solutions, prevention of intestinal overdistension. Fifth, prevention of overdistension and intestinal motility restoration. Evacuation of intestinal contents during the operation. Decompression at the post-operative period by means of intestinal intubation. Constant aspiration of gastric contents. Stimulation of intestinal motility and oxygen therapy. According to the date of Fedorovich and Chukrienko, from 38 to 60% of patients with acute ileus make complete recovery due to conservative treatment. Conservative treatment is used in case of acute commissural ileus, ileocecal invagination, sigmoid colon torsion, and ileus in the lower intestine. Most authors recommended performing conservative procedure within 2-3 hours. In case of correction of intussusception due to the conservative treatment, the patient is subjected to physical examination to reveal the cause of obstruction. Treatment of functional intestinal obstruction includes procedures directed on elimination of general processes, peritonitis, pneumonia, and other. Intestinal stimulation with all available means, proserine, uretide, pituitrin, hypertensive saline enemas, gastric and intestinal intubation, and paranephric blocks. In most cases, treatment is successful. If conservative measures are ineffective, urgent operation is performed. Preoperative preparation includes 1. Drainage of the stomach. 2. Introduction of preparation of regulation of respiratory and blood system, cardiamine, sulfacamphacaine, corglicone, and curantil. 3. Infusion therapy in the necessary extent, polyglucine and hydrocortisone in case of low arterial pressure, glucose solution, Ringer's solution, hemodase, native and dry plasma, saline and polyionic solutions. 4. Premedication, omnipron, atropine, dimidrol. The character of surgical intervention in different forms of intestinal obstruction is different, and surgical approach during operation is also varied. At present, a general endotracheal anesthesia with relaxants is considered to be an anesthesia of choice. An operative access should be rather wide. Usually a mid-median laparotomy is made. In commissural ileus, transection of adjacents is indicated. Excuse me. The abdominal cavity is washed with solution of fibrinolytics. Is performed to prevent peritoneal commissures. In case of formation of knots and valvulus, there is elimination of a knot or a valvulus is carried out. In case of necrosis, the bowel site resection is indicated. In peritonitis, applying of enteroanastomosis is performed. In cases of invagination, disinvagination is carried out. If it is due to Meckel's diverticulum, the bowel site together with diverticulum and invaginates, is resected. If the cause of invagination is the tumor, different variants are possible. At the end of the operation, at all types of intestinal obstruction, the surgeon performs a thorough sanitation of the abdominal cavity and blocks of mesentery root and introduce intubation decompression probes into the intestine. Prognosis depends on type of intestinal obstruction, the period of the disease, and timely surgical intervention. Thank you for attention. We finished our lecture.